On behalf of my co-authors, Dr. David Deal from the Geisinger Medical Center and Dr. Samir Grover from the University of Toronto, I'm Srinadh Komanduri from Northwestern University in Chicago. We'd like to thank the editorial board of Gastrointestinal Endoscopy for accepting our editorial entitled Trends in Endoscopic Training, the Impact of Subspecialization and Productivity-Based Compensation on Gastroenterology Fellowships. Over the last decade, we've seen tremendous amounts of innovation and new technology in the field of gastroenterology and endoscopy. However, despite all these advances, we really haven't seen this translate into adoption in clinical practice. Why is this happening? And the root of some of this is traced back to our gastroenterology training programs. If we start to look at our academic medical centers, one of the major shifts that's happened over the last decade is moving away from a salary compensation structure to productivity-based compensation. So that means almost in the traditional private practice model, our physicians who are asked to not only train our future generation of gastroenterologists are now being compensated in such a way that every procedure counts in terms of their bottom line. This ultimately puts significant pressure on our gastroenterology faculty who are tasked with training our next generation of gastroenterologists to not only be extremely productive, but allow trainees time such that they can learn common endoscopic procedures. As you would imagine, this has significantly limited our ability in training our GI fellows. You couple that with the development of our advanced endoscopy super fellowships or subspecialized fellowships, which have trained many, many advanced endoscopists across our academic programs. So we now have the ability to refer not only the complexity of cases that we may not be trained for as general gastroenterologists, but anything that might actually take more than the allotted time we have, given the pressure to be productive as a general gastroenterologist, can now be referred and almost used as a crutch to the advanced endoscopist. We've seen that happen in the world of complex polypectomy, and we've also seen this happen in other areas of endoscopy like esophageal dilation, and things which just may not fit the current model of productivity for general gastroenterologists, period. This also seems to be an issue where training programs who work in ambulatory surgical centers where complexity also may not be easily performed because of the operational environment of that practice setting. Ultimately, it's the gastroenterology trainee that suffered. Why has this come to light in 2024? What we have started to see is that our graduating fellows of general GI programs don't have the same endoscopic skill set as those of many years ago and even 10 years ago in our fellowship training programs. What do we mean by that? So complex procedures, or those that are thought to be complex procedures in 2024, were once thought of as standard bread and butter endoscopic procedures. And even more so in clinical practice or private practice today, many of these procedures are commonplace for general gastroenterologists. So whether that's PEG tube placement, complex esophageal dilation, complex polypectomy, there is an expectation for the vast majority of practices hiring our GI trainees that they can handle these procedures. However, we have seen the trend from our fellows that this may not be the case. And not only these fellows going out into practice and not qualified to fully take on their endoscopic role, some of these faculty are becoming our junior partners in academic medical centers and being also asked to train the next generation, creating a vicious cycle. Now, ultimately, this is not a fault of the endoscopist, the trainee, or the faculty. This is a system that's broken. We cannot continue to ask our faculty under the current payment structure, the current compensation model, to spend significant amounts of time with trainees and the endoscope in the GI lab. It just doesn't make sense. So how do we move on from this? We absolutely need to start looking at newer compensation models for those faculty who are tasked to train our gastroenterology fellows in the endoscopy lab. They need more time. They need more cognitive attention to the art of endoscopy, and not just, hey, here's a few minutes on the colonoscope, or here's a few minutes to try to take out this polyp. And if you can't do it, then I take the scope over. And that type of mentality is resulting in suboptimally trained fellows. In addition, as we all are aware, gastroenterology is moving from a very diagnostic field to a therapeutic field. With the advent of AI technologies and blood-based testing, we are soon be in an environment where diagnostic colonoscopy, as an example, won't be what it is today. And many of us in the next 10 years will be asked to shift our practices from a purely screening type of mentality to a therapeutic mentality. So not just looking for colon polyps, for example, but nearly every patient having a complex or a large colon polyp. So if you really look at that with the environment of training we're in right now, where each year our graduating fellows may feel less and less confident in some of these complex procedures or perceived complex procedures in this day and age, we have a significant problem. So we, as fellowship directors, as academic physicians who work with trainees, need to come together with our societies and look at ways to fix the situation. There's no question we need to create a new paradigm for teaching and really understand how compensation can be modeled for those faculty who have the privilege to teach the next generation. In addition, we need to look at novel ways to accelerate learning curves. This has been done through simulation, whether virtual or ex vivo. There are lots of tremendous models that we can work with. We've done this at Northwestern with models around polypectomy. And imagine a fellow coming into their first colonoscopy, having taken out 50 or 100 polyps in an ex vivo setting, really understanding all the technical caveats before doing this on a live patient. While these are available in select institutions, we have not seen a standardization of this across the country. I would consider this editorial as a call to action to all of those in academic training programs to start thinking about and start looking at our graduating trainees, asking them about their comfort levels with basic sets of procedures that are what our average gastroenterologist might do in clinical practice. We then need to turn our attention to these solutions. How can we all come together and work as one to look at things like simulation, to look at virtual reality-based settings, and ultimately compensation or a structure for our teaching faculty who can go back to spending adequate time for those amazing gastroenterologists of the future. Again, we thank you so much for accepting this publication. We look forward to hearing everyone's thoughts around this problem, but we do think it's something that needs to be addressed moving forward. We thank you very much.